Promovida South Zimbabwe. Quero também contigo, Zimbabwe. Uma dança nova, mistura de samba com samba de mambo com rumba, tua mama minha e a minha na tua. Balanceie, balançaia, swinga para lá, swinga para cá, yeah. Balanceie, balançaia, Maria José, swinga no pé, se não chega para lá.
Hello and welcome to today's seminar, Gender Equity in Health Data Analysis. This is the 5th in our 7-part series on gender foundations and health data. For those of you who don't already know me, I'm Dr. Michelle Kaufman, and I lead the Gender Equity Unit of the Data for Health Initiative. I hope you enjoyed our opening musical selections today by female artists from France, Spain, Argentina, Portugal, and Cape Verde. Today's panelists are a unique blend of gender experts, biostatisticians, and health data analysts who work in the field. This group is reflective of the teams that are necessary to conduct gendered data analysis in collaboration with ministry gender champions in order to improve health outcomes for all people in Data for Health countries. As you know, the Gender Equity Unit of Data for Health is housed at the Johns Hopkins Bloomberg School of Public Health. We have resources and expertise in gendered health data analysis and can collaborate and provide technical assistance to your in-country teams as you work to use CRVS, cancer registry, and household data collected for gender responsive program and policy impact. Please feel free to reach out to us anytime if we can be of help. Now, I'd like to introduce our moderator for this session, Vidhi Maniar, a member of the Data for Health team here at Johns Hopkins. Vidhi is a research associate in the Department of International Health. She provides strategic, technical, and analytic support for the Data for Health initiative and oversees research project operations, including communication and collaboration with multiple internal and external stakeholders in the US, Bangladesh, Colombia, Tanzania, and Uganda. Her research interests include designing and testing new or innovative strategies and techniques to deliver and optimize health intervention in low and middle income countries. Vidhi holds an MPH in epidemiology from New York Medical College and a master's degree in clinical nutrition and dietetics. Vidhi, I am so pleased that you're joining us today. I'll turn it over to you.
Thank you so much, Dr. Kaufman, for that nice introduction. Hello, good morning. My name is Vidhi Maniar, and I'm delighted to be moderating this panel today. The agenda for the seminar will follow the traditional format. We will be hearing from each of our panelists in turn, beginning with Rosemary Morgan, a professor at the Bloomberg School of Public Health, who will present an overview of the gendered analysis of health data. Next in line, we have Gayane Yenokyan, also from the Bloomberg School of Public Health, who will teach us about proxy indicators for gender equality and methodologies for gendered analysis of health data. Lastly, we have Onikepe Owolabi from Vital Strategies. She will then share their approach to analyzing national reproductive health data for gender equitable decision-making and policy-making in Rwanda, Uganda, and Bangladesh. After these presentations, I will host a discussion with the panelists, and then, as usual, we'll take audience questions. Let's get started by introducing our first speaker, Dr. Rosemary Morgan. Rosemary is an associate scientist at Johns Hopkins Bloomberg School of Public Health in the Department of International Health. She's also the associate chair in IDARE, which stands for Inclusion, Diversity, Anti-Racism, and Equity for the department. Rosemary has expertise in gender analysis, and intersectionality, and works as a gender advisor on a number of health and health systems projects, including leading the Sex and Gender Analysis Core for the NIH-funded Sex and Age Differences in Immunity to Influenza Center. She also acts as a co-PI on the MAGE project, which explores integrating gender and equity within monitoring and evaluation for reproductive and maternal health. She currently teaches a course on gender analysis in health research and interventions at the Bloomberg School. She also holds a PhD in international health and development from the University of Leeds. Welcome, Rosemary. You have 8 minutes, and I will help you keep track of time.
Great, thank you so much. And thank you so much for inviting me to be here today. I am going to talk or provide an introduction to gender analysis of health data. So for those of you who are experts in this area, this won't be new to you. Next slide, please. I wanted to begin with just a really quick overview of what we mean by gender and juxtapose that with gender power relations versus gender identity. So when I'm talking about gender analysis, I am referring to gender power relations, which is the first definition on the screen there, the socially constructed roles, behaviors, activities, attributes, and opportunities that society deems appropriate for men, women, boys and girls, and gender diverse people. Gender identity is definitely an aspect of gender, but gender identity is different in the sense that it is an individual's personal sense of having a particular gender. And one's gender identity can be the same or different from their sex assigned at birth. I wanted to start off with this distinction because often what I find when people do gender analysis, they start off by disaggregating their data, or they disaggregate their data by men and women, between men and women, and compare and stop there. But what I am arguing today is that gender analysis is much more than that. Next slide, please. So how you ask about each and collect data on each very much differs. Sociodemographic questions will ask about gender identity as opposed to gender power relations. And we often do find gender identity is conflated with sex in a lot of studies and projects. And it is assumed that a person's gender identity and biological sex match. And while gender identity facilitates sex or gender disaggregated analysis, it is not gender analysis as an entry point for gender analysis. And asking about gender power relations is more complex. And that's what I'm going to be focusing on today. How do we ask about gender power relations? Next slide. So just very quickly, this is how one might or would ask about biological sex in a survey. As you can see there, asking about male, female, intersex, or choosing not to disclose. Next slide. This is different from gender identity. And on the screen here, I've included 4 options from least inclusive to most inclusive. And what you choose would very much be dependent on your context. I often advocate for the most inclusive, but that is not always appropriate in all contexts and studies. I really like the open-ended question, but sometimes that can be difficult to analyze and give you different, very different results that you didn't expect. So there are different ways to ask about gender identity. Next slide. So when we're talking about gender analysis, what do I mean? I mean the process of analyzing how gender power relations affects people's lives, creates differences in needs and experiences, and how policies, services, and programs can help to address these differences. Next slide. I'm not going to go over all of this. The main takeaway message I wanted to show you is that, that gender analysis includes many steps. So on the right, you have the WHO Gender Assessment Scale, which looks from gender unequal, gender blind, gender sensitive, specific, and transformative programming. And I'm today only focusing on the foundation, the bottom of the pyramid here. So there's a lot more to gender analysis. Next slide. So let's first start off with sex and gender desegregation. I mentioned before that it is an entry point for gender analysis. So this is when you collect and tabulate separately for men and women or gender diverse people, and it allows for the measurement of differences between men and women. You can do gender analysis within sex or gender specific or sex or gender desegregated studies or projects. And what I mean by that is a sex or gender specific analysis would be in a project that maybe only focused on women, like maternal health, for example, whereas sex or gender desegregated, maybe you're doing HIV or TB, a project focused on that, and you want to desegregate data. You can do gender analysis in both. You don't need sex or gender desegregated data to do gender analysis. And this is where this sort of the gender power relations come in. Next slide. So as I mentioned, the data desegregation is a trigger for deeper reflection, and it's fundamental to understand, the effect of gender on program efforts. A fundamental way to understand is to desegregate by key indicators by sex and gender. We can see where differences might exist in inequities, but not why. And that's where the gender power relations component comes in. Next slide. Just a brief example here. This is data from UNAIDS that looks at new HIV infections in sub-Saharan Africa. And it disaggregates by sex or gender and age. And as you can see here in the 25 to 49 category, it's almost equal between men and women on new infections. Whereas in the 15 to 24 category, there's a huge discrepancy where women are being more infected they have more new HIV infections than men, so men and boys, right? So this we can see this inequity, but why? Why is that difference there? That's where the gender analysis can come in. Next slide. So one of the things where with gender power gender analysis is to ask about gender analysis questions. Did we skip over a slide? Can you just go back? I just want to make sure. No, okay, thank you. All right, next slide. So asking about gender analysis questions. So these are help us examine the why and how of gender power relations that between and among men and women. And to do this, we often use proxies to understand gender power relations. And this is because it can be very difficult to ask about gender power relations directly. And to figure out which proxies we should use, we often use, or I always use, gender framework, which is an established way in which we understand or we recognize the ways in which gender power relations manifest. Next slide. Here's a gender framework that looks at the ways in which gender power relations manifest as an equitable access to resources, an equitable division of labor and roles, and equitable social norms, and inequitable roles in decision-making. Next slide. Here is just an example of some illustrative gender analysis questions, particularly in relation to maternal health, that might be relevant for these areas. And on the right, you can see some example proxies for understanding gender relations. So these proxies I might turn into questions in my data sets to ask about income, to ask about education, employment, time spent doing health work, ability to leave the house without permission, or perceptions of gender-based violence. These are just examples. It's not exhaustive. There are many more. But here I'm breaking down the ways in which gender and power relations manifest as inequities. Next slide. This then can be turned into gender responsive indicators in our projects, which help us measure where inequities and health outcomes between men and women and subgroups exist, help us understand why, track whether health inequities are growing or shrinking, and really help to assess, understand, and measure changes. Next slide. There are different types of gender responsive indicators that map on to what I was talking about before. You've got the sex gender specific indicators, which pertain only to women or only men. You've got the sex gender disaggregated indicators, which measure differences between men and women. And then gender equality indicators, which measure gender inequality directly or are proxies. This is where the gender frameworks come in and the proxies. So indicators related to maybe income and education and perceptions. Next slide. Here are some examples of gender equality indicators in the DHS. I won't list all of them, but often when I'm doing this type of work, I will pull from validated indicators, and a lot of those are pulled from different DHS. And here are some that I have used in my studies: decision-making about small and large purchases, absence of GB fee, changes in attitudes, control over earnings. And then what I will do is assess the relationship of these with different health or health systems metrics to see the role that they play. And does, for example, women's increased autonomy relate to increased access to antenatal care, or relate to decreased access if they have a lack of autonomy? Next slide. And finally, I wanted to end with just some additional resources to point you in directions. There's a gender analysis toolkit for health systems, which provides a gender framework and instructions on conducting a gender situational analysis to inform programming. The incorporating intersectional gender analysis into research on infectious diseases of poverty really goes over a lot of the steps that I went over today, using frameworks and questions and indicators. Well, infectious diseases is kind of a case study that steps and tools can be used for any health or health systems topic. So I will stop there and thank you all.
Thank you, Rosemary. That was just in time. And also thank you for laying the foundation for this seminar by describing gender health data analysis. And now I'd like to introduce our next speaker, Dr. Gayane Yenokyan. Gayane is an associate scientist in the Department of Biostatistics, Johns Hopkins Bloomberg School of Public Health, and also executive director of the Biostatistics Center that provides methodological and data science expertise to a wide range of partners at Johns Hopkins and other academic research centers, health research organizations, and governmental agencies. Trained as an epidemiologist and biostatistician, she has been practicing statistical consulting for over 15 years. Her robust research portfolio includes a joint publication with colleagues in GDEC, which stands for Global Disease Epidemiology and Control, where the team assessed evidence-based decision-making in designing maternal, neonatal, and child health interventions in low and middle income countries. Her statistical research interests include observational case-based designs, design and analysis of clinical trials, and longitudinal modeling of complex outcomes. Dr. Yenokyan received her PhD from Johns Hopkins Bloomberg School of Public Health and an MD from Yerevan State Medical University in Armenia. Welcome, Gayane. You have 8 minutes.
Thank you very much for this wonderful introduction, Vidhi, and thank you for having me. So I'm going to take some ideas that Rosemary already introduced, and I'm going to talk about a framework specifically for developing and thinking about gender norm proxy indicators and how they can be used in analysis and hypothesized to affect health outcomes. Next slide, please. So Rosemary essentially laid the foundation for some of the gaps in the data and measurements that exist with respect to gender analysis and gender norms. So what I'm going to talk about this last point is about in the absence of validated measures for gender norms and how they affect the outcomes, how can we think about proxy indicators and how we can develop them in different situations. So next slide, please. So this is a framework that was proposed to particularly think about the gender norm proxy indicators. So I'm going to talk about this framework briefly, and then I'm going to try to illustrate some of the uses using 2 particular case studies. So on the top left on this framework, essentially it starts with the question as to whether or not we have a direct measure for gender norms in our analysis. And so if the answer is no, then we're going to proceed to the next step to try to think about the best proxy indicators for gender norms to be used in our analysis to understand the underlying why questions. And so in this case, then we might have a couple different ways to think about these. So for example, if we're looking at particular behaviors and then how these behaviors are visible and available, so then maybe use the behaviors to think about a proxy indicator. Another situation might be when the behaviors are not directly measured. And so we might want to use the attitudes towards certain behaviors. And so then maybe even produce a derived measure that can be used as a gender norm proxy indicator. And then on the right-hand side of this framework is then thinking about how these gender norms come in. Proxy indicators can be used to analyze the relationship with different outcomes and what those mechanisms can be. Next slide, please. So the case studies that I would like to talk about for the rest of this presentation is one, thinking about a particular example of intimate partner violence and how gender norms can be hypothesized to affect this power relationship. And then the second one is how gender norms can affect the risk of HIV. And so these are two particular cases that I'm hoping would illustrate this framework. Next slide, please. So this is the first case study, thinking about intimate partner violence. So first I'll describe the data set and the setting, and then I'll go on to think about the methodological aspects of these. So let's go back to the previous slide, please. Thank you. So the data set that was used in this particular analysis is the Nigeria Violence Against Children Survey. It's a national representative survey of 13 to 24-year-olds. And of course, it's a survey, national representative, so it includes survey sampling. And so particularly, we're interested in understanding what the primary sampling unit is in this survey. So these were the communities. We can think of them as communities of variable population size. So that's important for when we talk about the methodology for the proxy indicators. And then what's important here is that thinking about a particular hypothesis. So the research question was how we examine the relationship at individual level of female labor participation and then experiencing intimate partner violence. And then how then this relationship might be changed or modified by the female labor participation norms that exist at the community level. And so the particular hypothesis here was that if we think about these communities, so there might be communities where participation in labor outside home might be counter-normative. So it's not considered normal as a gender norm for women. And so if for these particular communities, then husbands or partners of women who work for pay outside home, they might be subject to ridicule and then respond by being violent with their wives. So that's a particular hypothesis that we can examine using this gender norm proxy. So the gender norm proxy that was developed for this particular case study was the cluster level female participation in paid labor outside the household. So let's now go on to the next slide and talk about how this analysis was done and how this proxy was developed. So as a first step, and this is again the part of the diagram, the framework that I showed before, is to think about clustering, right? So we have survey data where we have the primary sampling units, and so this can be thought of as communities. So within community, we can examine the correlation of different measures, which would then indicate how similar are the community members with respect to different measures. So in the analysis, actually, where it started, first the analysis was done to correlate attitudes towards intimate partner violence. So actually correlating the attitudes towards the behavior itself. And what was found that there was a low inter-class correlation that indicates that there is not such a high similarity within the community with respect to their attitudes. So that indicates, in fact, a high heterogeneity and something that is not normative within the community. So if it's not very highly correlated across members of the community. And the second step then was done for the actual behavior, looking at the female labor participation, a behavior that can be directly measured in the survey. And then thinking about then intra-class correlation for the behavior itself. And that then was found that there seemed to be a norm that exists within a community. So that was a part of the exploratory analysis to see where might be this norm that exists. And then the second step was thinking about, once we think about what the gender norm is, we're going to use the female labor participation as a gender norm in the community, then think about how we can classify the communities based on this gender norm. And so what was found, again, interestingly, is that for majority of the communities, about 70% of them, the female labor participation outside the home was less than 30%. And so then these communities were labeled as counter-normative with respect to, so restrictive with respect to female labor participation. And then the last step then, because we already have a specific research question and specific hypothesis that we wanted to test, we can look at the relationship first at the individual level, looking at the individual level labor participation versus experiencing intimate partner violence and adjust in the model for other factors, such as marital status, age, education, but then subdivide the communities and then look at these relationships separately in the communities where this labor participation is counter-normative, and then the communities where it is normative. And so as expected, as the hypothesis was stated, there was found this positive relationship between female labor participation at the individual level in intimate partner violence, but only in the communities where the norms were restrictive. So this is essentially then illustrates that the proxy norm, gender norm indicator that was developed essentially addresses the research question and is in line with what was hypothesized. Next slide, please. And this is just to, again, there is another animation. So if you can click. Right, so we start with by the absence of a direct measure. And so we started by thinking about gender proxy for gender norm. Then another click, please. And then there was a behavior, in this case, female labor participation that was directly measurable. And then that was developed into a gender norm. And then the last click here is on the right-hand side, how it affects the outcome. So in this case, it was a modifier for the two individual level predictor and the outcome, and it essentially changed that relationship. So next slide, please. So this is my second case study, thinking about the risk of adolescent HIV status. So this was this was developed using the DHS survey. And so particular DHS survey, so looking at cross-sectional data. And then this was also the sex stratified analysis. So thinking about that the relationships between gender norm proxy and the outcome might be different by sex in this case. So the outcome was the young people's HIV status. And then the research question was, what are the norms that exist in the communities with respect to premarital sex? And then so that was the first proxy. And then the second proxy was the thinking about places where there is a negative attitude towards premarital sex, but there was actually a behavior that existed in the community. So the contradiction between the two but between the attitude and between the behavior. And that that contrast was used as a gender norm proxy. So the research question is, the sexually active young people in places where marital sex is counter-normative, places where people hold negative attitude against it, but still do it, then that would affect their behavior. So they will not seek medical advice. And that would then in turn result in higher risk of HIV. So the gender norms proxy that was developed is what they labeled as a taboo gap. So there is a contrast between the community level or the cluster level reported attitude and the cluster level data-derived behaviors. And so then, as I mentioned, a sex stratified analysis was done to look at this, the gap, the taboo gap at the cluster level, and how it affected then risk status for the HIV. Again, this was a hypothesis-driven analysis. And then the next slide, essentially just to illustrate with respect to the framework. So if you click again, we start in the absence of a particular direct measure for gender norm. And then we go on, if you click again, to develop a proxy for the attitude toward the behavior. And in this case, the attitude was directly measured, whether or not you approve of premarital sex. And then the second proxy measure was whether or not the behavior actually existed, which was a derived measure, which again, in turn, reduced the potential bias in measurement. So there was a contrast between the actual age at the first sex and then the actual, the age of the marriage. And so then this derived measure then allowed to develop the behavior-based proxy. And then the contrast between the two then allowed us to use it in the analysis. And if you click again, then the idea in terms of how this contrast affects the health outcomes was actually avoiding something positive, a positive behavior, like for example, seeking health or medical advice, which then result in higher risk for HIV. So I'm going to stop here, and then here are some references, including the paper that I referenced with respect to the framework for developing these proxy indicators. Thank you.
Thank you, Gayane. You did an amazing job of explaining statistical research methodologies to an audience of health professionals. We will now introduce our next speaker, and just before that, we'll be addressing questions the audience might have for all our three esteemed speakers during the Q&A at the end of the panel discussion. So please feel free to submit questions as we go along. Our next speaker, Onikepe Owolabi, is the Program Director of the Data-Driven Policy Initiative to Improve Women's Health at Vital Strategies. She currently oversees the implementation of programs aimed at strengthening the use of national reproductive health data for decision-making and policymaking in Rwanda, Uganda, and Bangladesh. Over the past 12 years, she has led and contributed to research and design of interventions and evaluations to improve population-level measurement of maternal morbidity, facilitate access to sexual and reproductive health services for women and girls, and measure and improve the quality of sexual and reproductive healthcare in multiple countries in sub-Saharan Africa, as well as Southeast Asia. She is deeply invested in increasing access to high quality evidence-based reproductive healthcare for women and girls, improving the methodologies used to measure different reproductive healthcare conditions, and advancing and improving the use of locally owned health data for decision-making in low and middle income countries. Dr. Owolabi has a PhD in epidemiology and population health from the London School of Hygiene and Tropical Medicine, and a Bachelor's of Medicine from Obafemi Awolowo University in Nigeria. Welcome, Oni. You have 8 minutes.
Thank you very much, Vidhi, and I'm very excited to be speaking with you all today. Thank you so much, Rosemary and Gayane, for laying a really good foundation. Now I'm sort of going to narrow in on my work as Vidhi described, and I'm going to be talking to you about why collecting and analyzing incomplete and most likely biased data for some aspects of sexual and reproductive health is very critical and important for gender equity today. And throughout my presentation, I will be speaking primarily about women and girls, acknowledging that gender is not binary and people who do not identify as women can and do experience the health conditions I will speak about. Next slide, please. Click, please. One click, please. The ICPD 1994, the International Conference on Population and Development, was a watershed and revolutionary event for people who work in the field of sexual and reproductive health, which I'll call SRH after, because it established a common global framework and language to be able to talk about sexual and reproductive health, and within this, the inherent human rights of women and girls. That said, after this meeting was held and propositions were made and countries signed onto this, some of the more contentious aspects of women's SRH, such as comprehensive sexuality education, safe abortion services, infertility, treatment of sexual dysfunction, and gender-based violence, continue to be treated as entirely separate domains from the more traditional SRH topics like family planning, maternal health, and HIV prevention and treatment. And this continues to make it easy to exclude them from financing, programming, and policy. In 2012, the SDGs were launched, and they tried to set more comprehensive targets for countries. And the target 3.7 focuses on aiming to ensure universal access to SRH care and services, including family planning, information and education, and the integration of reproductive healthcare into national strategies and programs. That said, if you look at the tracer indicators used to evaluate SDG 3.7, it's met need for family planning satisfied and adolescent birth rate, which are of course, again, limited to contraception and maternity care. And whilst we can argue that these tracer indicators are used because data on them exists, it doesn't sufficiently broaden out the definition of SRH for women and even men, and it continues to limit the tracking of indicators that are important. Click, please. Established in 2016 and wrapping up in 2018, the Guttmacher-Lancet Commission developed a comprehensive, evidence-based, bold, actionable agenda for sexual reproductive health and rights globally. They defined SRHR as the right of all individuals to make decisions about their bodies and lives free of stigma, discrimination, and coercion, and to have access to essential SRHR interventions. And they included all people, they explored gender broadly, and they chose not to focus on people predominantly as parents or families. And so they recognized reproductive autonomy in a way that many SRHR charters haven't done previously. This background is essential because understanding the politics of SRHR within countries and how you have to frame definitions when you're working with governments and conducting research studies, and the political will that exists to address health conditions that are important to all genders is necessary for advocacy and for research and measurement. Now I'm going to cite a few global statistics for you on some of the less talked about aspects of SRHR before I go into my work. Click, please. About 25 million unsafe abortions were estimated to take place worldwide between 2010 and 2014, and majority of these were in low and middle income countries. Now, although these statistics look horrific, I can tell you that most of this is modeled data because there's very low availability of routine health administrative data and survey data on abortion in this context because of stigma. Click through, please. 50 million couples worldwide experience infertility yearly, and this is a 2012 statistics. However, we know that it's very hard to measure infertility because there's no consistent definition. There are not many health services for it, and it's not routinely documented in low and middle income countries. Click through, please. Globally, about 27% of women are reported, of reproductive age, are reported to have experienced physical, sexual, or intimate partner violence in their lifetime. Now, this is another horrific statistics, but this data is based on model data, and the data set used to generate this data consists of 366 eligible studies capturing the responses of 2 million women, which is barely a blip in the ocean of the number of women in the world. Last click through, please. And of course, there's a substantial burden of female cancers, breast and cervical, most of which occur in low and middle income countries, predominantly in sub-Saharan Africa, affecting women. And Vital Strategies is doing a tremendous amount of work to establish cancer registries in the context with the highest burdens and actually collect data on these cancers which affect the lives of women. Next slide, please. Now, I'd like to share a little bit about my work at Vital Strategies and the Data-Driven Policy Initiative for Women's Health. It's a program in Bangladesh, Rwanda, and Uganda, and it was conceptualized to reduce the adverse impact on unintended pregnancy and to help improve the policy and program environment for maternal and reproductive healthcare that is safe, that is equitable, that is stigma-free, and to reduce disability and deaths to women of reproductive age. We work with governments to evaluate their routine health information systems, which will of course put a limit on how gender responsive our analysis can be because of the availability of data and proxy indicators like Gayane has described. We take a strong focus on deprioritized and non-traditional SRH indicators. We're conducting data quality assessment of the health management information system and working with government agencies to build their capacity to collect this data, routinely analyze it and integrate it into their technical and strategic conversations, present this data by themselves to policy level stakeholders, and use this data as a foundation for sound decision and policy making. Next slide, please. However, there are very many challenges to collecting and analyzing data on non-traditional and often very stigmatized SRH conditions. Like I show you in this diagram, stigma is a dynamic, deeply contextual social process wherein people are negatively stereotyped because of their association with something, being non-gender binary, abortions, gender-based violence. And my diagram highlights how people are embedded in families and close and extended communities. And all of these things come together to influence their perceptions, their actions, and their social reactions to very many SRH conditions. I'm going to quickly describe how data on abortion is available in many contexts with restrictive laws. Could you click, please? Thank you. Now, even though I'm going to speak specifically to abortion, you could pretty much replace this with gender-based violence or adolescent comprehensive sexuality in education. Now, restrictive abortion laws exacerbate the stigma that people experience as individuals from their families and from their close communities. And the fear of security risks to researchers or providers of abortion services and the challenges of collecting reliable data and implementing research on a stigmatized and potentially illegal condition affects the number of women who will report on this accurately. So whenever you try to collect data on abortion, it's always underreported in surveys, and that's the tippy top of my pyramid, which are pretty popular because who wants to tell you they did something where their whole community will look down on them? When you go down the pyramid, health facility records may have more information on admissions for abortion-related complications. In many contexts, it is underrecorded by clinical staff to protect themselves or actually to protect their patients from legal repercussions. But then when you look at the two parts at the top, it does not include all women who don't come into hospital, including those who die at home. And thus, the data we have tends to be for women who have much more autonomy. They're urban, they're educated, they can get to a hospital. The data we see in hospitals is for those who could potentially afford to go to a health facility, and those who we don't have data on are those with less resources and less privilege. They're younger, they're poorer, they're less educated, they live in rural and remote areas, they're disabled, they're marginalized tribes, they're refugees. And we know that women do not experience these conditions alone. There's often a lot of intersectionality, and so disadvantage tends to exclude you from data and from being counted. Next slide, please. Next slide, please. Oh, could you click through? Yeah, thank you. I'm going to end with how we plan to analyze this data in our work to explore equity amongst women in the context we work. If you look at the pyramid again, everything I've talked about is a particularly important condition. But like I said, it is easiest, if at all possible, to get data on women and girls with the most autonomy for conditions that are stigmatized or restricted by law. And so when we conduct our data analysis, as we're starting to do in Rwanda and Uganda, we're very careful about interpreting our findings. We need to explicitly acknowledge who is represented by the health administrative data the government has, who is not counted. And very often we need to continue to explore why. Looking at equity, we want to highlight groups who are already known to be marginalized and whose needs need to be better understood. And even though it is very basic and not the gold standard, we start by looking at age disaggregation. What is the distribution of these reproductive health conditions in people of different ages? What is the geographical distribution? What parts of the country are poorer? What parts of the country are remote? What parts are less accessible? In addition to looking at established indicators or proxy indicators for access and for autonomy, as much as we can within health administrative records, we try to look for emerging patterns of differential access and outcomes. For example, in Uganda, trying to look at the distribution of abortion-related complications, we've noticed that a lot of complications are concentrated in border states, states that are connected or districts that are connected to other countries. And then the question has become, is this an incoming refugee, are these incoming refugee populations in parts of Uganda? Why does it look like complications are concentrated in places that should be potentially remote but border other countries as against in the center of the country? We ensure that we will look at other relevant indicators and complementary quantitative information to put our numbers in context. And so we're looking at unintended pregnancy, we're looking at education status, adolescent birth rates, contraceptive use, all the proxy indicators that tend to be readily available to understand women's experiences and why they might be experiencing greater burdens of disease. And then lastly, we will conduct qualitative interviews with diverse stakeholders to put our numbers in context and to understand the disparities we find. In summary, from this case study, what I'd like to say is it's important to note that even though we have to try to provide the best data available on this kind of gender indicators within SRH for women, it is important to acknowledge that there are many that cannot currently be counted or counted completely, but they are still critical and important to analyze the best way we can to ensure that women have complete access to healthcare and that they meet their sexual reproductive rights. Thank you very much.
Thank you, Oni. This was amazing. And clearly we have a lot to learn from the experiences you've had working with Vital Strategies team and the population level data sets. So now we get to the exciting part. We have a few questions that we ask the panelists, and then the panelists have 3 minutes each to answer those questions. Getting to the first one right away. We know that gender is only one factor that affects cultural norms and ultimately health outcomes. Can you please speak to how you might address intersectional factors such as class, race, ethnicity, sexual orientation, and disability when conducting a gender analysis of a data set? I would start with Rosemary first, then we can go to Gayane and then Oni. Rosemary, mic's to you.
Sure, great, thank you. Yes, I think that's a really important question because for me, you can't do gender analysis effectively if you're not bringing in an intersectional lens that looks at how gender intersects with other social stratifiers and how this leads to individual experiences of marginalization or advantage. And it is a complex thing to do. I often use, when I'm bringing in an intersectional gender lens, I use gender as the entry point because gender and equity affects everybody, just in different ways. It affects men, women, and gender diverse people. And however, the ways in which gender intersects with other social stratifiers means that again, people's experiences are different. And if we're not bringing in that lens, what we're doing is we're saying everybody's experiences are the same. And that actually what happens is those that are more privileged or advantaged is actually the examples that are being represented. So if we're not, for example, additionally disaggregating by race, we're missing unique experiences of Black women or racial minority women, depending on the context that you're working in. Again, it is a complex thing to do. What I would do is, I talked about the sex and gender disaggregation, but then the gender equality indicators looks at proxy indicators. I would then take those proxy indicators and disaggregate them further by the social stratifiers of interest. And we also often have to, we can't do all the social stratifiers. We don't have time, we don't have resources. We're going to need huge, gigantic data sets to do that. And we have to put boundaries on things. So it's important to think about which ones are most relevant for my context. And then I also argue that for me, actually finding significant findings isn't always the goal. I'm interested in trends. I'm interested, in those individual experiences. So, I think wherever possible, we should be providing intersectional data. We should be demanding it. We should be asking it, because otherwise what we're doing is perpetuating the status quo. We're bringing to the fore, like I said, those experiences that are most privileged.
That's a great answer. And as an epidemiologist, I couldn't agree more. It's so important to measure trends. Next, Gayane, let's hear what you have to say.
Sure, it's very hard to add. It was such a comprehensive answer, but essentially just to reinforce that, one, that we do need all these stratifiers that make up for individuals' experience, right? So it's one thing we were talking today is the gender norms, but of course, all these other important characteristics make up for the thinking about the outcome and what people experience and what we're trying to measure. And I think one thing to emphasize is that every particular question and every particular outcome could be thought of within a particular setting, and two, within the particular, what are the most important and relevant stratifiers that we need to measure and report. And then the lack of the measurement that needs to be also reported. And I really like on this interpretation towards the end where she was talking about who my findings generalize to. That's important, right? So it's who we could measure, who we could report on, and who we couldn't is as important as just the significant findings that Rosemary was talking about.
Oni?
Like Gayane said, it's really hard to top that. I agree with everything they both said. And just to add a little bit, I think the one thing I have been seeing as I work less with individual level data and more with aggregate data is where possible, looking at not just the individual's experience, but then their experience based on where they are. And so in some of my data, I've been saying that it's not just how you identify your intersectionality, but where you are. For example, people who identify in a certain way, but for some reason live in places where all health facilities are Catholic hospitals, are then going through a very different experience as against if they lived in the tribe or district where they're originally from, or the sense of otherness. So women from a very different part of the country are thriving less when they relocate to other places simply because, as it were, they're strangers. So in addition to like the individual intersectionality, how is it sort of interacting with your current environment or where you are?
Thank you for answering the question. Now for our second question. So as we identify that it can be challenging to learn about cultural gender norms in a specific country or a region, as so often the norms and stereotypes are embedded in a community's way of life and even its laws. Can you speak more to proxy indicators as a way to learn about gendered norms to inform a gendered analysis of population health data? I will start first with Gayane and then move to Rosemary and then Oni, if that sequence is fine.
Sure. So if we think about the case studies that I was talking about, essentially part of the question is that we think about the context, the question itself, right? What are the relevant gender norm indicators that we can think about? Right. So to me, part of the question is, it should be hypothesis driven. So what are some of the influences that we have to explore within the question we're asking for a particular health outcome or for a particular relationship? And then, of course, understanding the community and the country context is really important that comes into play. Right, so these questions cannot be explored in a vacuum. They have to be put in the context of, what are some of these, what are potential power relationships that exist, or the legal system, or the community norms and beliefs. So to me, there are two aspects. One is, creating hypothesis that is informed by the particular context, and then exploring some different proxy indicators within that general framework for a particular setting.
Rosemary?
Great. Yeah, I think you're absolutely right that some of these things sometimes are so embedded in a context, and as such can be really difficult. I liked Oni's title of presentation of counting the uncountable, because I actually think we're forced a lot to count things that are so much more complex than what our data sets allow for. And I think norms is one of those things. I actually would advocate for qualitative research to accompany this, to unpack. That being said, we have to sometimes work within these restrictions, right? And I've done a study myself where I did the steps that I explained. I used a gender framework to come up with, gender analysis questions and associated proxy indicators that and we developed a women's questionnaire and a men's questionnaire, and it was around maternal health. And we were restricted in needing to have validated indicators, and I can't remember what of the other presenters actually said. I think it was you, Gayane, actually, who said that we were actually restricted because there's a lot of things that aren't unvalidated, and we can't just come up with our own questions. I mean, sometimes we do, but I didn't give it that luxury. So I was pulling from, data sets like DHS data sets to trying to find what are some sort of norms and beliefs, and across the different domains. So I talked about inequitable access to resources. That was one of the easiest domains to find indicators. Rules and practices, it was easy, but we actually ended up not including those in our study because of how labor intensive they are to collect, time use surveys and things like that. We had some questions. Decision making and autonomy was fairly straightforward, but it is a complex thing to get to it. But norms was one of the hardest. And just some examples that we used, for example, we used norms that were both positive and negative. So things around, should a husband accompany his wife to A&C? Should a husband accompany his wife to delivery? Got around norms of male engagement and whose responsibility it is. A question around contraception is a woman's concern, only got around norms. There's a whole series of questions about, does a woman have right to refuse sex with her husband or not? A whole series of questions about when is it acceptable for a man to hit his wife? When she refuses sex, when refusing money, things like that. Questions around childbearing is a woman's concern. These are some of the normative based questions that we use to get at this. But my thing would be you can never rely on just one question. You have to look across the set, right? You have to look across, and then you have to look across the domains too. That's why it's like gender power relations, it's complex. We've got to unpack it. We've got to see, what's coming out, but it is something that we can get at. But again, I would strongly advocate for other forms of data collection, like qualitative, participatory methodologies to really get at some of these things.
There's a lot of good information for all our audience members, so I hope everyone appreciates that. And moving on to my next question, we often see gender analysis being conducted by partners outside of government. Are there good examples of gender analysis of population data sets being initiated by governments and in collaboration with outside partners? What are some factors that could facilitate this type of government ownership? And so if you could speak on that, that would be great. We can start with Oni this time and then move to Rosemary and end with Gayane.
And thank you. I think that's a great question. Like Rosemary said at the very beginning of her presentation, population data sets, well, you could broadly split them into surveys, or, routine health administrative data. I will say that in many countries, governments do rely as heavily on surveys like the DHS or MIX as they do on routine administrative data, because those systems are not well developed everywhere you go. Depending on what you're looking at, I think, gender disaggregation for government often looks like male, female. And, depending on what condition, they will look at it broadly in that way. Within a lot of my work in women's health, when they try to take it further, equity starts to look like age disaggregation. And, they're very proactive about looking at things in age groups and potentially districts or provinces, whatever geographical, catchment area makes the most sense for them. I think most governments are sort of good at that, but then digging a little bit deeper into the whys is something that we encourage them to do in our work. They're often very knowledgeable about their context, and the advantage of that is when we talk to them or engage with them, they can say, oh yeah, this district, the girls don't drop out of school very much, or they have low contraceptive prevalence rates. And so we try to encourage them to think of those whys, especially when it comes to developing programs and interventions. However, the flip side of that is when you're deeply embedded in any context, sometimes stereotypes and biases arise, and there's a tendency to write off it because, oh, these people are that way. And so then you have to sort of walk people through explaining why this is a problem that needs an intervention, and how it's at the community level, and it's not a population just not being advanced or choosing not to do something. How can you intervene appropriately to create access, or bring in behavioral change, and to address whatever health condition you're looking at. I think another thing that facilitates government ownership, which we do a lot in Vital Strategies, is in our work, we sort of work within an embedded model where our in-country staff, statisticians, epidemiologists are seconded to Ministry of Health. And so we talk to them directly, but they sort of lead from the front the analysis we do. For example, I get a lot of data and he's like, okay, I did it by region, and then you're like, plot it on a map, and then you ask questions, and as an outsider, why do I consistently think this is higher there? Because you don't know the answer, but it prompts them to look, and they're like, oh, I don't know that. And then, they can go back to other departments within the Ministry of Health, and they ask questions about the population of these people, and has it changed? In Uganda, it has a lot to do with, are there more refugees here? Is it because of the camps? What's going on? And so, we try to foster ownership in the way we work with people in country to do our analysis. And I feel like many partners, including my colleagues on this presentation, probably do the same. So I'll hand it over now.
Gayane, next.
Sure, thanks. I don't think I can add too much except to say we as statisticians are helpful in the sense of asking trying to highlight the data and trying to help ask the questions why, or why certain groups are underrepresented, or why certain trends are apparent in the data. So I think that's kind of the way we usually partner with our in-country researchers or in-country governments. And then another thing, just to say, I mean, we're sort of here to be available as a resource. So that's something else that, I can offer at this point, to sort of partner and try to think about how to ask these questions.
Yeah, that makes sense. And over to you, Rosemary.
Sure. Yeah, that is the question, isn't it? How do you get buy-in from government? Oh, I wish I had a straightforward answer, but I don't. And I also, part of your question was, do we have examples? I don't, but it's not to say they don't exist. I mean, look at when we were mining DHS data sets for questions to include, we had to go far and wide. There was quite a variety, and there was some contexts that it was clear there was much more emphasis on gender. I think Malaysia was one of them, if I remember correctly. And the trick is, it's like, how do you gain buy-in for gender analysis from anybody? And one of the things is because what I find in these data sets is people go straight to the health questions. How are you accessing antenatal care? Are you using a skilled birth attendant? They see it as directly applicable. But the questions I'm proposing on first glance aren't directly applicable, right? Do you have you worked in the last 7 days? Do you have a mobile banking account, right? And trying to sometimes advocate for that can be a challenge. But what we need to do is use sort of evidence-based arguments. There is evidence out there. And when you can clearly show the relationship between gender inequities or gender power relations in these health outcomes, the argument then is, if we want sustainable change, we need to move more upstream in our interventions, or do we need to ensure our health interventions are also tackling inequitable gender norms, right? So I think, it's a big question. How do we get buy-in? I think, evidence-based arguments, participatory, collaborative approach is really important. These sort of swooping in top-down approaches don't work, So, I wish I had a more straightforward answer, because I think we'd be further along in the gender and health world if we had more of these analyses.
Yeah, I wish this was more direct than, but I think I see a lot of progress compared to before. So that's a positive that I now, that I see now. So thank you to all three of you for addressing these questions. And now I'm looking at the chat box and taking in some questions from the audience as well. We have first audience question, which is, I think, addressed to Dr. Rosemary. So Dr. Morgan, I was taken by your identification of 3 types of gender indicators: gender specific, gender disaggregated, and gender equality indicators. Can you please review and give examples of each? If you can do that in light of our data for health work, collecting death registration data, or non-communicable diseases such as cancer or heart disease, that would be great. Thank you.
Oh, just putting me on the spot. I don't know if I can in that spot give you exact examples, but especially with the examples that you're asking for. But what I can say is, to me, this difference between the sex and gender, and I moved to sex/gender disaggregated when I think it's actually gender disaggregated, because we're not talking about biological sex, per people's chromosomes, and there's a time those questions are very relevant in some contexts. So to me, it's actually gender disaggregated data, even though we commonly use sex disaggregated. So the difference between a gender disaggregated data would be, let's say, like the example of a gender cancer, I heard that in there, of sex gender specific indicator would be the amount of women going for breast cancer screening is a gender specific indicator, because it only pertains to women, right? Not necessarily true, actually, but breast cancer was probably not the best example, because men can get breast cancer too, but
True.
You can see what I mean there. I use like A and C often for that. The gender disaggregated might be the amount of amount of men and women going for breast cancer. If I was only interested in women in my study, and that's perfect, that's fine, I would use the gender specific indicator, amount of women going for breast cancer screening. If I wasn't interested in men, I would say amount of men and women going for breast cancer, and I would compare. And then I would bring in other indicators to see, do we see differences between subgroups? Whereas the gender equality indicator is using those proxies. So I would want to know why, if I see a difference. So often the gender equality indicators help us explain the differences that we see in the gender specific and gender disaggregated. So if we see a disparity, is it because certain women lack autonomy and decision-making power? Certain women lack education and information about it. certain women have a lack of access to transportation to get to there. Like there's the gender quality indicators kind of unpack to get at the why. So I often see like gender specific and gender desegregated, very numerical, looking at prevalences and percentages. I'm looking for disparities, whereas gender equality now tries to unpack why those disparities might exist.
Thank you. And Oni, what do you think about this?
Put me on the spot again. I think Rosemary did a fabulous job with that. I mean, what do I think? I think the gender specific, a lot of my work focuses on very gender specific indicators. So, you know, I think she gave a really good example. I did like the gender disaggregated, and I think how I would also look at it is, in addition to looking at something like breast cancer from like a CRVS point of view, it would be, what is the proportion of men who get screened for the most common male cancers as against women who get screened for the most common female cancers, because it's a really good way of looking at and you would be actually be surprised by that answer in very many contexts, that men might be lower even though they have more power and more money because they tend to access healthcare less, would be my hypothesis. But just trying to understand equity in access to healthcare and in resources, and you know, the availability of routine screening in certain places. So that would be one way in which I would approach like the topic of cancer. For CRVS, I know there's often lots of questions about mortality, and you know, if you're doing a survey or something, what proportion of male deaths are reported versus female deaths, when there's often a disparity between that. I guess they said NCDs for cardiovascular disease, which is, you know, really important. What is the prevalence of hypertension by gender? You could also look at that and then try to understand, you know, screening, or even if it's who has access to medications, who is taking them frequently. If you have, it's very rare to have that kind of data at the administrative level, but I do think that prevalence of hypertension and diabetes is critical. And for CRVS, I know that mortality is one of the biggest unresolved issues, and it is often differential for inheritance laws. So those are other things I would be looking at as between gender disaggregated and gender equality. And like Rosemary and Gayane have said, then it's very important to explore why. Like once you see there's a disparity, the question is why, and how can you drive change? So if it's inheritance laws, that's much harder, because then people will always register male deaths if it's patrilineal. Can this change in matrilineal societies? Can you incentivize or find a way to increase, you know, female death registration, which is a big issue for me. Yeah.
Mm-hmm. That was a great answer. So thank you for going deep into that, Oni and Rosemary. Dr. Gayane Yenokyan, fortunately or unfortunately, we haven't forgotten you. So the second question is addressed to you. And could you please walk us through the flowchart in your slides for how to do gender analysis? I think, yeah, the slide is being set.
Yeah. So this particular framework is thinking about, you know, those gender norm proxies, right? So if we start on the top left, right? So the question asks, do these direct measures exist for gender norms? So the people's opinion about the people's beliefs about others, what they're supposed to be doing, the behaviors. And so if those exist, then we can use those direct measures. But the whole diagram then goes into, if we don't have any direct measures of gender norms, then that's the second step, again on the left, use potential proxies, develop potential proxies. Then the next question is, do we have something that is directly measured directly measured as, for example, of visible behavior? And again, thinking about the case studies that we went through, is if there is a woman working outside the home, right? So that's the direct question that can be measured in a survey. So we can use it to potentially cluster at the community level and look to see, one, are the community members similar enough within the community on average? this issue of clustering and calculating a correlation. Is there a high correlation within a community that makes people more similar with respect to this type of behavior? And then thinking about the percentage at community level as a proxy for, what proportion of women actually participate in labor. And again, low versus high would give you some ideas, and the distribution of these percentages would give you some ideas. So in the example, again, going back to the first case study, they actually found that there is this big separation. Most of the communities have very low female labor participation outside home, and some very small number actually have a pretty high, above 30%. So the 30% essentially emerged as the cutoff. And so that would give you an idea. Here's a group of communities that have really low female labor participation outside home, and these are some of the minority of communities that have a higher. So that gives you an idea that there might be something normative going on with respect to women that's not viewed as a norm. It's restrictive in terms of women being allowed to work outside the home. So that was the first example. So on the left-hand side, there is that practice that is clearly visible and detectable. And then you use this proportion at the community level that can essentially serve as the gender norm proxy. And then this right-hand side of the diagram, then thinking about the health outcomes. So in this case was the intimate partner violence, and then hypothesizing how this community level norm about women and whether or not they can work outside the home, then how that comes into play. That's why I always say it's good to have develop specific hypotheses, again, understanding the context and what would be important in terms of potentially affecting the health outcome and potentially coming into play. So that was just the first one. If we go back to this left type again, trying to develop the norms, the gender norm proxies. If there is a behavior, and I'm going now down to the box that says, is the practice something people are likely to express their opinion about? And that was the part where you can ask an attitude question, right? So you might have available questions about, are certain people need to be behaving certain way type of question. It's the attitude type of question. So again, that was an example from the second case study where they looked at the attitude towards premarital sex. So again, there is a direct question that is there. It doesn't really measure directly the behavior, but it does measure the attitude within a community and whether or not, again, that can serve as a gender norm proxy in the analysis, then that potential proxy affects the outcome. And so in the second case, then when looking about what is the health concern related to in this center of the diagram, then we're going avoiding potential positive behavior. And in this case was potentially a sexually active young people will not seek medical help and might then be at higher risk for HIV because of this existing norm that then affects their seeking health advice. So essentially what this diagram does is helps you think about if we need to develop proxies, which essentially most of the time we do, for these gender norm indicators, do we have to think about a potential direct question that asks about certain behavior? If not, is there a direct question that asks about potential attitude? And then we can cluster within the community, and that's the third column on this diagram, to kind of see, are there any similarities within the community with respect to either behavior or the attitude? And then the next question is, let's think about the health outcome and how this gender norm proxy can affect these outcomes we're looking at. So I don't know, I hope this is comprehensive, but I can take some questions on this.
I think you feel that really well. And I'll move to the next question. I think this one is probably, this one could be fielded by Oni. Not me. I didn't mean to put you on the spot, but I think this one's for you. So cross-referencing of data from multiple sources requires sharing of data between different departments and ministries, which can be a challenge. More so if there is hesitation to prioritize gender equity. What strategies can you share that have enabled data sharing in your work?
I think this is a really good question. It doesn't have a straightforward answer, unfortunately. So I'm not going to tell you exactly what you can do. I can tell you that it depends on how the country is constituted. Like you said, the willingness to work on gender equity, how data is stored and flows between departments, who has permissions to what. And those are all things that we as external partners don't have a lot of control over. In places, even in countries where there is a willingness to work on gender equity, as it were, and communicate, very often we found that we need one central person to connect us with other people. And so in our work in Rwanda, we have someone who, and I'm working on health, like I said, so I will draw examples from that, who sits in the HMIS division and thus sort of has connection to all the potential data we could want to look at across different departments and conditions. And so if we needed something, then, it would be going to that specific person and asking them to please, if we want it from maternal health, if we want it from adolescent health, could you please reach out to them? And we're happy to talk to you, do a presentation. Like, these are all soft skills, explain why, and we want to use that data. In some other countries where it's a very pluralistic health system and data is very siloed, for example, Bangladesh has multiple departments working on different things. We're investing a lot of lag time at the beginning of the program, bringing together different departments and explaining why we need their data to work in tandem. And this is in and of itself challenging. Like I said, it's not a clear answer, but presenting your approach. We've had open conversations on why working on these particular topics are important for women's health and for equity within women's health, on why we need to work with both agencies. We have separate agreements with both agencies, but we're at the point where in principle it is agreed that we will work together and we will both contribute data. And sometimes maybe this is the strength of being an external stakeholder, is they're both willing to contribute data to us centrally to work on, and they're currently in a place where they're trying to see if within their different departments they can facilitate an internal data sharing agreement. But for the purposes of this program, after the conversations we've had, they are willing to both share their data to be used for this. And so, like I said, it's not a straightforward answer. It's you explaining why, giving a cost proposition, why this is a cost-effective thing to work on, why this will increase equity and rights. We try to draw on their own health documents and tie it into their own goals or objectives to make it clear to them that you have these internal SDG goals, you want to fulfill these. And if we make a strong argument, we hope that then they are willing to communicate across other departments. The other things we do is we draw on available reports, so financial reports, population level reports, the things that are published on ministry websites. We take them, we try to do very simple ecological analysis or elegant models to say, these are simple correlations. If we have access to detailed data, we can look at more things for you. So, you take what you have within the DHS published reports from their own government and say, but if we have your direct data and we can link data, then our analysis is stronger, and you hope for the best. Thank you.
Thank you, Oni, for that solid answer. And this brings us to the very end. And thank you, Gayane, thank you, Oni, thank you, Rosemary, and the audience for being part of the seminar today. And now I will turn the mic back to Dr. Kaufman for closing remarks. Thank you, everyone.
Thank you, Vidhi, and thank you again to all of our panelists and to the audience for such thoughtful questions as usual. I especially enjoy the focus on data analysis as it pertains to gender, so I was geeking out over here. We hope that today's seminar has started you thinking about how you can integrate gender data analysis into improving health outcomes for all people in your own work. We are asking that data for health partners spend the next few minutes taking a brief knowledge check on the materials presented today. This will qualify you for a gender equity certificate at the end of the seminar series. The knowledge check is offered in French, Portuguese, Spanish, and English. You can scan the QR code in the slides on the screen or use the link in the chat. The Zoom webinar will stay open for the next 10 minutes in case you have any issues accessing the knowledge check. Otherwise, we hope to see you in 2 weeks on Wednesday, the 20th of April at 9 a.m. Eastern Standard Time, 1 p.m. Greenwich Mean Time for the next seminar in this series, using health data to develop gender responsive policies. Thank you, everyone.